Good afternoon and welcome. My name is Sahil Parikh from Columbia University in New York City, and I'm delighted to be joined by my partner, Dr. Eddie Choke from Singapore. We're going to kick off the symposium, which will review, I think, in some detail, the Concept Medical Magic Touch clinical trial program and our clinical experience. We will be joined remotely by Dr. Aloke Finn, who is my co-resident and friend for many years, now practicing in Maryland, and an interventional cardiologist who is a world expert in the pathobiology of vascular restenosis. We'll also be joined by Francesco Liistro, who's here at this meeting, hopefully will be joining us shortly, and Dr. UIf Teichgräber from Jena in Germany. So without further ado, Aloke, we're going to put you up on the screen, and we're going to ask you to talk about, is sirolimus a better option for PAD treatment?
Great. Sahil, can you hear me?
We can hear you just fine. Thank you.
Perfect. Let me just, can you see my slide? Let me just put you on full screen, and then we're
stand by, Aloke. We're waiting for them to put your slides up. Here, we got you. We got you.
Okay. Gotcha. Fantastic. Sahil, thank you. Always a pleasure to be on the podium with you, and you obviously have lots to share on this subject, so this should be a very interesting symposium. I'm going to give you some background on the Magic Touch Sirolimus Coated Balloon and some evidence of its efficacy on preclinical models and rationale. These are my disclosures. As you guys are familiar with, I think that there have been many important innovations in the field of interventional vascular medicine. Especially in terms of the advent of POBA, bare metal stents, drug-eluting stents. I think the Sirolimus DCB obviously represents the latest and probably the most important new innovation that's going to take place in this field in recent history. And so I'm going to go do a deep dive with you on that technology. As you're familiar with, paclitaxel is currently the go-to drug for drug-eluting balloons or drug-coated balloons. Most of them that have been FDA approved, all of them at this point, have had paclitaxel. And paclitaxel really works by crystallizing the form of paclitaxel on the balloon surface. And those crystals then are deposited onto the arterial wall in really depots. And you can see that here shown on the higher power histology. Those depots then slowly break down over time and form a soluble form of the drug, which is bioactive, bioavailable, and that's what really allows you to have a sustained release of paclitaxel over time. Like any crystalline material, unfortunately, it can shatter, just like your crystal in your kitchen will shatter. And coating a balloon with a crystalline material, while it's effective in terms of its anti-restenotic effect, has certain unwanted characteristics. One of those obviously is coating. It's very hard to get the transfer of the drug, all of that drug, to the arterial wall without shattering or breaking that coating. And some of those crystals then deposit downstream. And that's one of the biggest issues with this technology, is loss of a lot, and some people say 80% of the loaded dose never makes it to the arterial wall with paclitaxel. And we've shown in preclinical models that these deposits of paclitaxel crystals can be found downstream in muscle beds or tissue beds that are downstream of the affected treated organ. For instance, in the preclinical model in the SFA, if you look down at the downstream skeletal muscle beds, you can see evidence of embolized paclitaxel crystals that are occurring in downstream arterioles. This is one of the problems with the current technology, and probably why it's not really representing the pinnacle of this technology. And this was shown by us in many different papers now. Here we show Lutonix and Impact, two balloons that were approved many years ago, and showing basically the number of distal embolization events in the preclinical porcine model where the SFA was treated when we looked at the downstream skeletal muscle. You can also assay that skeletal muscle downstream, and you can see that there's plenty of paclitaxel that can be found in terms of drug concentrations. This also leads to another thing I think Eddie's going to talk about, which is really problems with flow recovery after use of these balloons. If you get embolized paclitaxel down to the downstream arterioles, obviously you're going to start having slow flow, and your microvascular clearance is not going to be very quick. You can see here in this particular example, the SFA is heavily diseased. Post-POBA, the flow velocity actually increases, but post-paclitaxel DCB, it again decreases, again showing you an example of slow flow due to these embolic events I'm talking about. And this is certainly related to problems with wound healing and amputation-free rates of survival. If you have slow flow after the intervention, your chances of having effective wound healing and amputation-free rate go down dramatically. So this is an important clinical aspect to these balloons. Obviously, we know also we don't want to lose a lot of paclitaxel into the body because it's well known that it's a anti-chemotherapeutic drug, and it's got certain toxicities associated with it, including bone marrow suppression, neurotoxicity, nausea, etc. So you really don't want to lose a lot of the drug into the the non-target organs because they can have effects. We also know that sirolimus is a better drug for causing intimal proliferation, preventing intimal proliferation or restenosis. Here I'm showing you late loss curves from drug-eluting stents, so that you have paclitaxel-eluting stents or sirolimus or its analog stents, and you can see in every situation the late loss was simply lower for the sirolimus coated stents. Obviously we want to show a lot of safety for these products, and we want to show acceptable healing both early and late. We really evaluate time points during the drug presence and its absence to make sure the excipient carriers don't cause vascular reaction consistent with toxicity. And as I mentioned before, we look at downstream organs to see whether emboli occurred, and we also look at non-target organs. We assay them for blood levels of sirolimus or paclitaxel. We also look at the histopathology to see if there's any toxicity associated with them. The current issues surrounding sirolimus coated balloons, the reason they don't exist on the market or they didn't exist as quickly as paclitaxel, obviously is issues with tissue absorption and tissue retention, both of which are harder with sirolimus. The nanolute technology really uses a carrier, a phospholipid microparticle carrier onto which the sirolimus is put into, and it transfers those phospholipid particles to the arterial wall, where they elute over time and cause drug indwelling over time to eliminate or prevent restenosis. And this is an example of the Magic Touch Sirolimus Coated Balloon. And I'm just going to show you some of the preclinical data from the GLP studies that have been done with this balloon, just to show you some of the amount of data that's required for these submissions and how much safety is required. You can see blood levels of this drug start to fall below therapeutic range, 5 to usually 15 nanograms per milliliter within 72 hours, well within 24 or 72 hours, showing you a very good safety blood profile of drug. And the treated iliofemoral segment actually has sustained release of sirolimus out to at least 30 to 60 days, which I think is very good. The downstream muscles, as I showed you earlier with paclitaxel, really don't have much evidence of sirolimus emboli. As you can see, there's hardly any evidence of sirolimus concentration in the downstream skeletal muscles. Lungs have a little bit more, but lungs in any drug-coated balloon actually retain more drug than most organs because they're really central to the filtering system of the body. This is the porcine femoral artery model, which we explored Magic Touch versus POBA. This is the entire GLP study, 3, 30, 90, 180 days of both Magic Touch and POBA 1X and 3X. I'm not going to go through all this data because it would be exhausting to go through all of it at this very short talk. But in final summary of this GLP study, this is what was written. There was really no safety concerns found with this product, and I think that underlies its importance in terms of the clinical arena, where it will be coming soon. And the downstream emboli findings were really very little. We could see that of 9 of 12 animals showed evidence of downstream embolization, but you can see 7 sections with the Magic Touch 1X DCB, 4 sections with a POBA. So you even see emboli with POBA. And then same thing with the group. There was more emboli with a 3X Magic Touch, but still acceptable. And then histologic sections were within normal limits, and there was a few animals that didn't have them, but there was no evidence of skeletal muscle necrosis or anything worse. And the findings were hard to see. Findings were hard to see at 30 and 90 days. So in conclusion, I think I've shown you the drawbacks of paclitaxel coated balloon technology and perhaps the better safety profile of the sirolimus coated balloon, which is currently undergoing, it's just CE market undergoing FDA submission. So I think it'll be playing an important role with peripheral interventions going forward. So with that, thank you for your attention.
Aloke, thank you. We're lonely up here, so we'll get Dr. Liistro up here shortly. But a couple of questions for you, Aloke, if we can get you back, or we can hear you, I think.
I'm here. I don't know, you can't see me, but I'm here.
You're like the Wizard of Oz. So tell us about the tissue levels. You commented that tissue levels were resident out to 90 days. Are you
Yeah.
at therapeutic
Yes.
levels, and how does that compare to other devices perhaps that you've looked at from a preclinical standpoint?
I think 90 days is too long, Sahil. I don't think the tissue levels are therapeutic at the 90 days. I think they're probably in the therapeutic range in the 30 to 60-day range, which I think is, if you were to compare drug levels to a stent, drug-coated balloons really don't achieve the same amount of drug levels as a stent does. That's just the reality of it. And the distribution of drugs is a little more patchy within drug-eluting stents, but you don't have a carrier reservoir that elutes that drug over time. It's more tricky. You got to just inflate the balloon and hope it all stays there. So I don't think we should expect this technology to be as good as a stent in terms of the drug levels. I think it's good enough to cause some intimal proliferation, prevention of intimal proliferation. Eddie can talk. You know, the PK studies, Sahil, are really meant to support its efficacy, but we can never, as I tell many people, we can never tell efficacy until we get into the clinic and we have clinical data from clinicians like yourself who tell us their clinical experiences or it's in a randomized trial. Eddie can speak better than I can to the clinical efficacy of this balloon. What I can speak to is the fact that this balloon seems to be fairly safe, does not have issues with toxicity or emboli, that I think, Sahil, are significant factors in the use of paclitaxel-coated balloons, especially below the knee. Even the stent just failed. So, you know, I think this is where the preclinical ends and the clinical experience can take over.
All right, well, that's a perfect segue. So we're going to then invite Dr. Eddie Choke up to give us updates on the XTOSI trial of his Magic Touch for CLTI patients. He's going to present to us the 36-month results and the rationale for the future family of trials.
Thank you very much, Sahil. Thank you very much, Concept, for inviting me to this symposium. Can I have my slides up, please? Thanks. Great. So I'll be talking about the 36 months results of the XTOSI trial and also a little bit on the rationale for our future SFA and future BTK trials. These are my disclosures. So chronic limb-threatening ischemia is a major health burden. At the moment, POBAR is the gold standard for BTK, but this is hampered by high rates of restenosis and high rates of reintervention after conventional balloon angioplasty. So we conducted the XTOSI first-in-man clinical trial looking at the Magic Touch Sirolimus Coated Balloons for peripheral arterial disease. And our results were published last year, and this is up to 12 months. And for today, I would like to present to you the 36 months results. So just briefly about these trials, 55 patients were screened and consented, of which 50 were ultimately enrolled, of which 40 patients underwent 6 months primary patency endpoint, and we now have outcomes up to 36 months. In terms of the baseline characteristics, and these have been presented previously, so I won't go into too much detail about this, except to say that this is a typical high-risk CLTI cohort. And in terms of the Rutherford scores, we recruited mostly Rutherford scores 5 and 6, with high Wi-Fi scores above 4. And this was the key findings from the study. The first thing to say is that for the SFA group, N equals 20, the 6 months primary patency was 88%, and this was comparable to the paclitaxel 6 months primary patency from the Lutonics or the Ranger studies. However, for the BTK 6 months primary patency, and this was what got us quite excited, we were able to show that the primary patency at 6 months for BTK was 74%, and the reason why we think this is good is because we know from our previous trials that we can only get a 6 months primary patency of 40%, whether we use POBAR or whether we use paclitaxel-coated balloons. And this was a trial previously conducted by my peers in Singapore on the Singapacli trial, looking at the role of paclitaxel-coated balloons for BTK, and they were able to demonstrate that at 6 months, the primary patency was only 40%, so we were quite happy with a 74% primary patency for Sirolimus Coated Balloon. So we wanted to ask our questions at 36 months is how did the promising 6 months primary patency translate to long-term clinical outcomes? And these are the 4 clinical outcomes that we will be presenting in the next 4 slides. So the first thing to say is that in terms of overall survival, the survival is in line with a high-risk CLTI population. At 3 years, the overall survival is only 63%. In terms of the amputation-free survival, it follows a very similar curve to the overall survival, also 63%, and this suggests that the majority of the contributing factor to the amputation-free survival is by far due to death rather than the amputation itself. And this is the slide on amputation itself. We were able to show that at 36 months, the freedom from amputation remained excellent at 86%. You can see that at 12 months, we had 3 amputations, and between 12 and 36 months, we had an additional 2 limb loss. And this was mostly from sepsis. In terms of freedom from TLR, at 6 months, this was 90.5%, and at 36 months, we were able to sustain it to 84%. And the reason why it dropped down to 84% really was because the denominator had decreased quite drastically because of the deaths in this cohort of patients. There was only, in fact, in terms of absolute numbers, only an additional 1 TLR between 6 and 36 months. And this is one of the patients from the XTOSI trial in which we implanted, or we used a Sirolimus Coated Balloon for the SFA. And you can see that this was a Rutherford 6 wound, and he needed about 6 months for the wound to heal. And at 2 years, we were able to maintain the patency in the SFA. And in answer to Aloke's question earlier on about how long the drug remains, so the drug remains there for 90 days. Clinically, we can see that at 2 years, there was still patency. However, you can see that with any diabetic patients, they will start to have some disease coming back. So we do see the disease coming back. But the real thing is whether it translates to excellent clinical outcomes, and at the moment, in terms of amputation and also target lesion revascularization, it seems to be able to do that. And this patient, we were able to get him back to ambulate at about 1 year, and he's back to work as a taxi driver. And there's quite a nice story to this. When I came back from Charing Cross Symposium earlier on this year, it was just by pure coincidence I met him just as I was leaving the airport. And this is him at 39 months later. You can still see that, yeah, although he's coming out and he's not really wearing the proper footwear, he still has got a full healing of his left leg. And this is a typical patient on the anterior tibial artery, a BTK patient. Again, it took about 6 months for the wound to heal. And up to 2 years, you can see that some disease is starting to come back, but really still non-hemodynamically limiting stenosis. So in terms of the summary of the XTOSI 36-month data, there is good 6 months primary patency in both SFA and BTK, good 36 months clinical outcomes, low rates of reintervention, freedom from TLR was 84% with high limb salvage rates of 86%. So we've now gone on with this data to conduct in Asia the future SFA and future BTK trials, 279 patients for the future SFA and 219 patients for future BTK. These trials are double-blinded, 2-to-1 enrollment, recruitment across 18 sites from 4 countries, 100% CRO controlled with core lab adjudication of both duplex and QVA. And this is a summary of the flowchart of the trial. PD patients after screening for eligibility will all undergo standard angioplasty, and they will only be randomized after they fulfill intraoperative inclusion and exclusion criteria to receive either placebo and Sirolimus Coated Balloon. The primary outcome is 6 months primary patency as adjudicated by duplex PSVR of less than or equals to 2.4 in the absence of TLR adjudicated by core lab, and we will follow up patients up to 24 months. In terms of the key points of these future RCTs, I'd just like to stress that we took some time in really delineating the type of patient population whom we think will benefit from Sirolimus Coated Balloon. So the first thing is to say is that we excluded calcified vessels because we believe that this will form a barrier to the transference of drug. So we excluded patients with high calcification. We excluded patients with retrograde excess because the majority of these will be subintimal, and I think the biology of subintimal plane is quite different as to intraluminal planes. We excluded heel ulcers because in terms of wound healing, this is a completely different kettle of fish. We will allow long lesions up to 200 millimeters, and for BTK, it is only allowed to use the trial balloon in the proximal 200 millimeters only. And in terms of the reference vessel diameter, the smallest BTK balloon we will allow is 3 millimeters, because obviously in terms of sizing, the proper sizing is extremely important to achieve a good result. We will randomize patients only after successful vessel prep in order to reduce bias. We will also double blind both the operator, the treating physician, and also the patient and the core lab and the technicians doing the postoperative follow-up ultrasound scans. The balloons are labeled as either A, B, or C, and 2 of these will be Sirolimus Coated Balloon, 1 is placebo. And in terms of primary endpoint, we wanted to look at primary patency at 6 months, defined as PSVR of less than or equals to 2.4 in the absence of TLR. So in conclusion, ladies and gentlemen, Magic Touch PTA and XTOSI trial showed promising 6 months primary patency, and this was translated to promising 36 months clinical outcomes. We interpret this early data with caution, and we eagerly await the results of ongoing RCTs. Thank you very much.
Eddie, congratulations on incredible, groundbreaking work in the space. Tell me about your experience in these patients with deliverability of the balloon. Do you have any difficulties? Some of our newer technologies are not so easy to get down into the very distal segments.
This is one of the advantages I feel with Sirolimus Coated Balloons, is that as we got used to the technology, initially in 2017, when we first used this technology, we implanted it initially in a proximal SFA. And when we found that we haven't seen any slow flow phenomenon or any clinical distal embolization, we grew in confidence and we went down to BTK, and now we're putting Sirolimus Coated Balloons all the way down to the plantar arch already. And in my next talk, I will show you a demonstration of how there's no slow flow phenomenon even after using it in the most distal of arteries. So I'm quite confident that we don't see any slow flow phenomenon with the Sirolimus Coated Balloons.
Fantastic. So we look forward to seeing those cases. So why don't we move on?
Okay, I'd like to introduce the next speaker. He is a very well-known trialist in the BTK arena, Dr. Francesco Liistro, who will talk to us about cases and follow-up from the debate BTK DuelL RCT. Francesco.
So thank you for the for the invitation.
They're gonna pull up your slides.
Okay. Okay, so the debate BTK DuelL, it's a study comparing on below-the-knee arteries in patients with CLI, sirolimus eluting balloon, the Magic Touch, towards a paclitaxel eluting balloon, the Liistro DCB. You know, this is the flow chart of the study, so we are planning to enroll 172 patients in 4 centers in Tuscany. And there is a barrier to enter the study, which is an optimal angioplasty result, not judged only by angiography, but also by EVUS analyzation. We include patients, of course, with root of Rocklais 4, 5, and 6, tenosal occlusion at least 4 centimeters, runoff Kawarada, we will see 1 or 2 or 2B, and no flow limiting dissection. The primary endpoint of the study is the angiography at 6 months with a measure of late luminal loss, which is the more sensible endpoint to catch any differences in these 2 drug-eluting balloons. Secondary endpoints is 12 months TLR, target lesion occlusion, and major amputation. So for the Kawarada classification, we accept Kawarada type 1, type 2A, and 2B. We exclude type 3, but we may accept a tarsal artery filling directly the arch if we don't touch the tarsal and we don't touch the arch. So we give flow opening a tibial that goes immediately into the distal arch. Why there is a need to define an optimal balloon angioplasty to escape the problem of mechanical failure. As you observe in the best CLI trial, half of the population that have restenosis, they get restenosis in the first 30 days of follow-up. That means a mechanical failure. So we want to exclude this mechanical failure, and we define an optimal balloon angioplasty with a residual stenosis by visual estimation less than 30%, pulsatile flow in the duplex, no flow limiting dissection, and the pattern of the flow is really important on the duplex to see if you leave some residual stenosis. The primary endpoint is late luminal loss at 2 months, and the secondary endpoint is the major amputation, 12 months, target lesion vascularization, and vessel occlusion. The sample size is calculated to show a non-inferiority and a superiority with a margin of 10% and a power of 80. We need 172 patients to enroll. Up to now, we enroll only 62 patients, and 2 centers still didn't start yet. Which population are we going to face? You see a lot of patients with diabetes, more than 90%, and a lot of patients also with renal insufficiency. The majority of Rutherford classification is Rutherford 5 and 6. And we have an impaired inflow lesions in almost 40% of the populations, a very diffuse BTK district, and calcification in 80% of the patients. The majority of the culprit vessels is the anterotibial artery, followed by the posterotibial artery in both groups. The lesion, we are talking about long lesions, real BTK, real world scenario, more than 200 millimeter of lesion with a very high rate of occlusion, so 76 versus 74%. We have a good vessel reference diameter, 3.1, and we use, as usual, a DCB diameter of the same measure, so 3.1 DCB in mean in both groups. The procedural success is 96% because we have some flow limiting dissection, 1 patient in each group after the drug-eluting balloon. And so we are noticing that there was an impaired flow after the DCB and not after the preparation of the vessel. So now I'm going to show you some interesting cases with this Magic Touch balloon. This is a very long anterotibial occlusion with a very good reperfusion distally, so the vessel distally is really nice. And we advance, as you can see, the wire in a knuckle way, so this is a subintimal recanalization. We check the measure, it's a 2.9 in the distality. You see the wire advance in a knuckle fashion. And this is a pre-dilatation with a normal balloon, 3 millimeter, and we check the flow immediately after the dilatation. There is quite the same similar pattern in all the arteries. So we applied the drug-coated balloon. This is a Magic Touch 3.0, 200 millimeters, and the immediate result, as you can see, is really nice. Then we treat also in the same limb this stenosis of the peroneal artery with a 3.0 Magic Touch per 80 millimeters. And you can see that both vessels, the anterotibial and the peroneal, looks really nice at the immediate angiography. What about the follow-up of these patients? The 6 months angiography shows let me tell you, an incredible patency of the anterotibial artery. Incredible, and there is also, as you can see, a very important negative remodeling of the peroneal, and the flow is really nice, so the patients heal completely. The case 2, it's an horrible blunt occlusion of the tibioperoneal trunk in a patient with a posterotibial artery occlusion, a problem in the heel. And there is only one way to give some blood flow to the heel, is to reopen the trunk and reopen the peroneal. And so the posterior collateral from the peroneal goes to the heel. So we did a pre-dilatation with a 3.0 balloon. And as you can see, we reopen completely the peroneal. And we have some flow now to the heel. We apply the Magic Touch balloon 3.0, 200, and we restore completely the flow and a good vessel lumen in all the peroneal. And as you can see, we treated also, there was a stenosis in P3 segment, a stenosis subocclusion, but just a stenosis. So normally we treat with the balloon, and we use a normal balloon, achieving an acceptable result. But if you see 6 months later, there was a restenosis in the popliteal treated with a conventional balloon, while the peroneal treated with the Magic Touch is amazing. Very nice lumen and very nice flow, and the patient was almost completely healed. We can use the Magic Touch also in combination with IVL. This is a case of a sub-study of the DuelL, which is the debate BTK shock, and there was a very horrible lesion because it's an occlusion of the distal part of the anterotibial artery that we first dilated, and then we treated this vessel with an intravascular lithotripsy, and then we applied the Magic Touch. We achieved a very nice patency of the anterotibial artery, but for physicians that perform BTK interventions, they know that this type of lesion is really horrible. The distality of the tibials are really get a lot of chance to get restenosis. If you see 6 months later, the vessel is completely patent. What we had on the baseline on the left and what is on the right in the central view of the anteropedis arteries, you see the anterotibial is completely open. This is another complex case of dilation of the anterotibial artery, which is occluded from the proximal segment to the distality. So we are talking about 300 millimeter of occlusion of the anterotibial artery. What for us is routine practice. Every day we face these patients, and we are happy when we find that there is a distality, because the most difficult things nowadays is to find patients that have a good distality. In this case, we had a re-entry in the dorsalis pedis, and we applied a DCB. You see, this is 350 millimeters, 35 centimeters of drug-coated balloon, of Magic Touch balloon, 3.0 from the dorsalis pedis to the proximal, and 3.5 in the proximal ostium of the anterotibial artery. We restore the flow in the anterotibial artery, and the follow-up is at 12 months. I show you because this is really incredible. We had a pulsatility flow. We have a pulsation on the dorsalis pedis, and you can see that the flow is optimal. It's almost triphasic from the proximal to the ostium to the distal segment of the anterotibial artery. So this was really an excellent experience with the Magic Touch balloon. So in conclusion, DCB is a proper drug-eluting device to match BTK intervention. New study highlight the patency advantage of paclitaxel over POBA without safety concern, but the debate BTK DuelL will provide a head-to-head comparison of Sirolimus drug-eluting balloon, the Magic Touch versus the paclitaxel eluting balloon. A dedicated interventional strategy, which is included in the protocol, will limit the procedural bias that made the catastrophe of the previous study with the paclitaxel balloon, and of course will make the result, in my opinion, more reliable. Thank you.
Francesco, thanks very much. We're going to keep rolling here. It's just in the interest of time, and hold our questions till the end. I see Ulf is online. Ulf Teichgräber is the PI of the SIRONA trial. He's in Jena, and he's going to show us some cases and give us a brief update on SIRONA and LIMES.
Yes, so I'm just sharing now the presentation. Let's see. Hello?
Hey, Ulf, how are you?
How are you? I'm fine. So it's, I think, around 12 your time. It's evening here in Germany. So let's see if I can share now my presentation with you. I hope it works out. But not yet now. Why is it not working? Just a second.
Well, while we keep going, we'll wait for your slides to come up.
Yeah. I'll try to see again. I'm sorry about that. No, I see it. Okay, now it seems to work.
There we go. We see your slides. Yep, we got you.
Okay. Thank you for waiting. And I was asked to show some cases. I would like to show you 2 cases out of 2 RCTs for 2 phases of PAD. So one case from SIRONA RCT and another one from LIMES RCT. So why did I call this 2 phases of PAD? As you know, if we talk about PAD, we have really distinguished between apple and oranges. On the one hand side, we have the condition of intermittent claudication. This means walking impairment of our patients, mainly the stenosis or occlusion is located in the SFA. And on the other hand side, we have the oranges, which is a completely different condition. We are talking here about chronic limb-threatening ischemias, and this is mainly in the below the knee. And here, actually, we are no more talking about walking impairment. The main focus is on prevention of minor and major amputation. So if we 2 phases means we have 2 trials. One trial is the SIRONA trial. This one is really concentrating on intermittent claudication, and therefore the primary endpoint is primary patency at 12 months. Here we are comparing Parikh coated balloon against the Magic Touch, a Sirolimus coated balloon, and the approach is non-inferiority. And of course, we have also the second very important primary endpoint is the freedom from clinical driven TLR and major amputation. So it's a combined safety endpoint and mortality at 12 months. And on the other trial, LIMES RCT is now the orange, is concentrating on infrapopliteal target lesions. And actually, we are solely looking at total occlusions here, and we decided for a combined endpoint here. Of course, here, limb salvage is very important, and we combine this limb salvage with primary patency at 12 months. And for note, the primary patency is not only if the target lesion is patent or not. We are looking for absence of target lesion occlusion with restoration of inline flow to the ankle without the need of a TLR, meaning that really the outflow is important, not only that you have a nice open target lesion, the restoration of the inline flow is important, which is then also controlled with Doppler. So let's go back to the SIRONA trial. This is a head-to-head comparison, as already mentioned. This is a quite large trial. We have included nearly 500 patients in 2 groups, and there were in 28 study sites in Germany who were recruiting for this trial. We just finished in September the recruitment. And why is this so important to compare against paclitaxel? So a head-to-head approach. Well, on the one hand side, we know actually that paclitaxel works very well. We have this, this is one of our own meta-analysis, and the freedom from TLR after 12 months, we have a risk ratio of 1.24. That means most of the trials really the arm of paclitaxel profit against POBA, and even after 24 months we see even a higher rate of nearly an advantage of 40%, meaning a risk ratio of 1.39, which is so working perfectly. Does it really need then another balloon? Well, we all know that there is also some concerns about safety, and this is somehow also related on the drug which is used. We know that paclitaxel, as compared to sirolimus, is a cytotoxic drug, and therefore also we have some concerns of safety, as we know the all-cause mortality is still in discussion regarding paclitaxel coated balloon. So the rationale behind the SIRONA trial is based on the hypothesis that sirolimus is a non-inferiority to paclitaxel, so as good as paclitaxel coated balloon, and thus could be considered as an alternative treatment approach, especially for the condition of intermittent claudication. So one-to-one randomization, and the main inclusion criteria were claudicants, of course, Rutherford from 2 to 4, and we are here looking at restenotic and occlusive lesions up to a lesion length of 20 centimeters. And here one typical case out of our study from my study site, so Rutherford 2, a distal SFA CTO with a length of 40 millimeters. This was, we were able to have, with the first approach, a guide wire crossing of the lesion intraluminally. And afterwards, and this is very important, before randomization, the lesions have to be predilated. Predilatation has to be performed within a certain overlap, and the predilatation time was for both study arms before randomization 3 minutes. This is pretty long, but we want to make sure that really both study arms have the same good predilatation, because we know for long-term results predilatation is, of course, crucial. Here afterwards, the application of the Magic Touch balloon, also with a slight overlap of 1 centimeter with a 5 by 60 millimeter balloon. And here dilatation time was fixed by protocol of 1 minute. And importantly, the distal runoff was quite well, and the lesion, as you can see, final result without the necessity of stent placement. So with SIRONA, even under the tough condition of our pandemic situation with Corona, and even in my hospital, the ambulatory care units were closed, so claudicants really had problems to get appointments and even be scheduled. But still, with our 28 study sites, we were able to finish our recruitment just before time, after 1.5 years, which is quite amazing with such a high number of patients. And now I want to go to the other trial, the LIMES trial. LIMES trial is now comparing the Magic Touch against standard angioplasty, POBA, with a smaller cohort of 230 patients, so in 150 in each study arm. We have at the moment recruiting 19 study sites in Germany. We started quite 1 year later as with the SIRONA trial. And here we are in this trial, POBA and provisional bare metal stenting, the interpopulaire is standard of care, as we know. And however, results are often with POBA really unsatisfactory alone. And below the knee, superiority of paclitaxel coated balloon over POBA is still contradictory, and long-term safety results are quite conflicting, as we see in the recent study results from other trials which are performed with paclitaxel. Whether sirolimus, with its wider therapeutic range, is effective in the prevention of intrapopliteal restenosis and reocclusion remains still to be proven, and therefore this trial is very important to see that. Also the safety issue, especially for the risk of major amputation with paclitaxel DCB, is quite something which is on debate, as a recent meta-analysis of Casanos demonstrated. And as you can see, the number needed to harm is actually 35. In this meta-analysis, 11 RCTs were included. And purely in this graph, you see CLTI patients, as you can see clearly over time, always the risk for major amputation with paclitaxel coated balloon is quite higher than as compared to the control balloon, meaning POBA without drug coated balloons. So this is something which has to be kept in mind. You see the amputation rate is nearly doubled with the use of paclitaxel. Therefore, I think it really makes sense to have an alternative treatment option, especially below the knee, for this patient group. So this trial is also one-to-one randomized controlled. And we are now looking only at CLTI patients, infrapopliteal lesions, and only occlusive lesions. And also multiple and single lesions are allowed. Here I give you one case example. So rest pain of the patient in the right foot. The ABI was 0.5, and you see here several medical conditions. So a severely ill patient, and you see here an occlusive lesion, long occlusive lesion of the anterior tibial artery. And the first attempt actually from antegrade to pass the lesion was not successful. The second attempt was performed retrograde with a guide wire, and the cart technique was used, and therefore it was then possible to revascularize the lesion. So after that, after the guide wire passage, which was not that easy, vessel preparation was performed, and also with long dilatation times, the same as within SIRONA with 3 minutes. And afterwards, the magic touch with long balloons was performed with 2 long balloons to cover the whole lesion in the full length. So the final result, as you can see, very nice. Let's see how the patency will be over time. And as I told you, the restoration of inline flow is very important. So even after half a year where we reach our primary endpoint, we of course look then with Doppler is the restoration of the flow will be sustained, not only if the lesion is still patent, and also the restoration of inline flow is important for that. We are facing here completely different situation with CLTI as with our claudicant patients. The recruitment is extremely slow. We, of course, only have now 19 study sites, but we are far behind our schedule, completely different to the SIRONA trial. So we really have not many patients who consent to participate in such a trial. As we know, it's a difficult patient group, and not so easy in Germany and Austria to recruit the patient, because most of the patients do not consent to participate under their health conditions in a clinical trial. Therefore, what we actually now attempt is to include more study sites and to foster our recruitment this way. So let me just conclude. So femoral lesions in claudicants, our head-to-head approach. So SIRONA is a head-to-head approach comparing Sirolimus DCB versus paclitaxel DCB. Our main question is Sirolimus DCB non-inferior to paclitaxel DCB? So is it a real game changer in this field? And the LIMES RCT is focusing on infrapopliteal lesion in CLTI, comparison with standard of care, which is still POBA. And the question is Sirolimus DCB superior to POBA? And can we really prevent major amputation better than with POBA? Thank you.
Thank you, Ulf. We're going to move to Eddie Choke now, who's going to bring us home. Eddie's going to talk about his real-world experience with Sirolimus Coated Balloons. I would argue that Eddie probably has the most long-term experience with Magic Touch, so love to see some cases. And we're going to go a little over, so forgive us, but we will take some time for discussion.
Thank you very much, Sahil. So real-world experience of Sirolimus Coated Balloon versus standard balloon angioplasty for CLTI patients. So as previously presented, we published our XTOSI study last year, and really what was most exciting for us was the 74% 6 months primary patency for below the knee group. So our question was whether this was translatable to a real-world scenario. We've got the HOPE registry, which is ethically board approved, and from this HOPE registry, we were able to prospectively collect all our data on lower limb angioplasties in our hospital. And we looked at basically in a BTK subset of patients, patients who underwent Sirolimus Coated Balloon and also patients who just underwent standard uncoated balloon angioplasty. And the inclusion criteria was Rutherford's 4 to 6 CLTI patients, de novo lesions, below the knee treatment with either standard balloon angioplasty or Sirolimus Coated Balloon. And in terms of exclusion criteria, the patient must have had a successful angioplasty. And we have 128 patients who underwent Sirolimus Coated Balloons for BTK and 335 standard balloon for BTK. In terms of the outcomes studied, we focus on 4 key clinical outcomes: TLR, amputation, amputation-free survival, and also overall survival. And these are the demographics in the group. And really, the first thing to say is that this is a typical, complex, high-risk CLTI group, 90% diabetes, and also high proportion of patients with coronary artery disease. The second thing to say is that the groups are very well matched, statistically non-significant differences between the group. And in terms of the ASA scores, a majority were ASA score 3, with high Wi-Fi scores of about 4 in each group. In terms of the lesion characteristics, these are very long, diffused diabetic lesions, 230 to 238 millimeters in both groups. And this is a typical diabetic diffuse BTK disease that we see in our population every week, day in, day out. So, in terms of the results, 4 key clinical outcomes: TLR, amputation, amputation-free survival, and also overall survival. And this is the key slide that I want to present to you today. At 12 months, we were able to see that our use of BTK Sirolimus Coated Balloon was associated with a significantly lower CD-TLR with a hazard ratio of 0.6, so nearly a 40% reduction in the rates of CD-TLR. 78% versus 66%. So this means 2 things. Firstly, from our point of view, we were having to work less hard to try and save the legs of these patients. We were needing to re-intervene less in the Sirolimus Coated Balloons group. And from the patient's point of view, they're having to come into hospital, and they're having to come less to hospital for another intervention if they were to receive Magic Touch Sirolimus Coated Balloon. This is the result in terms of 12 months freedom from major amputation. The first thing to say is that in our hospital, the limb salvage rate is already quite good, 90% for standard uncoated balloon. As for comparison, we're able to see another tertiary hospital where the 1-year limb salvage was 75%. However, Magic Touch PTA Sirolimus Coated Balloon was associated with an even higher freedom from major amputation, although this did not reach statistical significance. In terms of overall survival, again, very typical for high-risk CLTI group. At 1 year, 20% of patients had died in both groups. In terms of amputation-free survival, because the survival was very similar in both groups, there was no difference in amputation-free survival in the Magic Touch group versus the standard uncoated balloon group. So to summarize our real-world CLTI patients, Magic Touch PTA Sirolimus Coated Balloon was associated with significantly lower CD-TLR. There was also associated with low amputation rates, although this was not statistically significant. And there was the same survival as a standard balloon angioplasty, so no issues with safety concerns. And this was in an all-comers real-world CLTI population with high cardiovascular diseases, high Wi-Fi scores, with long lesion lengths. So really, why is preventing TLR so crucial? Because you can see this is a typical CLTI patient's journey. This patient underwent successful angioplasty, and at 2 months, the wound seems to be healing. But during further follow-up at 3 months, the wound has broken down, and when you scan the patient, you can see that there was a significant restenosis of the anterior tibial artery. She underwent another target lesion revascularization, prolonged wound care, and she's back on track after about 4 months. So from the patient's perspective, really preventing TLR is crucial to their journey in terms of trying to save their legs. So what makes sirolimus coated balloons ideal for BTK disease? We know POBA is still a gold standard. PCBs for BTK is equivocal and potentially harmful, as shown from previous trials because of issues with distal embolization. For sirolimus coated balloons, you've heard about the superior biological parameters, but I also want to talk about the absence of slow flow phenomenon, which I think will become more talked about in the next few years. So this is a typical patient whom I've done an atherectomy. You can see to your left-hand side, after POBA, really nice brisk flow down. However, after application of the paclitaxel coated balloon, you can see a typical slow flow phenomenon. And we define slow flow phenomenon as anything more than 10 frames per second compared to the baseline post-POBA. You can see here highlighted in the red box, the frame rate. There was only 8 frames to get down to the bottom. However, after using paclitaxel DCB, it increased to 26 frames. So at our hospital, we looked at our prospectively collected data. We retrospectively reviewed our angiograms. Using the same definition, we found that in our paclitaxel-coated balloon population, the slow flow phenomenon was detected in about 12% of patients, whereas we could identify no slow flow phenomenon in the sirolimus-coated balloon. And what does this mean? In terms of our cohort, we saw that slow flow phenomenon was associated with higher amputation rates and poorer amputation-free survival. And this is a typical patient whom I applied the Magic Touch PTA down to the posterior tibial artery and also all the way down to the plantar arch. And the reason why I did this was because this patient had a large Rutherford type 6 wound, and we knew that she's going to take a long time to heal. So this is the baseline angiogram. Post-BOA, you can see a brisk run, and post-Magic Touch, you can see that there was no slow flow phenomenon. So really, to conclude, ladies and gentlemen, Magic Touch PTA for BTK showed promising results in terms of the XTOSI first-in-human trial, and this was translated into a real-world CLTI population with an associated reduction in TLR by 40% with absence of slow flow phenomenon. And like I said earlier on, we await the randomized controlled trial data before we can say anything definitively. Thank you very much.
Great. We're going to take the moderator's privilege and take another 5 minutes to just discuss this because we have such a great panel. So let's start with Ulf and Francesco. So both of you are going to have head-to-head trials looking at paclitaxel versus sirolimus DCBs. In earlier sessions here at this meeting and other meetings, there's been a lot of discussion about questioning the value proposition of sirolimus versus paclitaxel. I think many of us believe that in order for sirolimus to become the de facto standard, we need these kinds of head-to-head trials. How well do we need to perform? Ulf, do we need to be just non-inferior, or do we need to be superior in the SFA for claudicants? And Francesco, in the Bologna segment, the same question to you. So Ulf, I'll give you the first crack.
Great questions.
For the SFA, as I hopefully pointed out, we are looking at claudicants, and it will be extremely tough for a Sirolimus Coated Balloon to be superior to paclitaxel because it's really highly effective. We all know this from most RCTs which we're performing or comparing POBA with DCB, or even head-to-head trials also show that with paclitaxel coated balloons there is certainly differences between different types of balloons, but still most of the balloons are quite effective regarding the intima hyperplasia restriction. And therefore, I think it's no more question that it works. There, I think in the SFA head-to-head can only be a non-inferiority approach.
Francesco, what about the Bologna?
I think that the most important difference will be once we have a nice patency in both groups is the fact that paclitaxel can increase inflammatory response in the vessel. And this is, we already saw in the coronary, because the difference 20 years ago from the Taxus stent to the Cypher stent was the thrombosis. And I did, for first in the world, in 2001, we did an analysis of the histology of restenotic tissue from a quad-scoop P2 stent. There was a paclitaxel stent in the early 2000, and we show fibrin deposition, necrosis, inflammation, and so that was not in Sirolimus in the Cypher stent. So I believe that in below the knee, if we have a nice patency, maybe this patency will last more with Sirolimus compared to paclitaxel, because once you get inflammation, you get thrombosis, and you know, thrombosis of tibial artery is always asymptomatic. You just find an occlusion of the vessel, and maybe after some months you will get a new recurrence of CLI. So this is, in my opinion, the point to catch. Nice efficacy and very nice safety profile.
So, and I think in the absence of a gold standard in the below knee, it's possible to be superior on multiple levels. So I think that's maybe a key distinction between the two territories. Aloke, do you agree that the inflammatory and downstream embolic complications may make Sirolimus Coated Balloons superior for below the knee application in CLTI patients?
It's possible, Sahil. I think it's those trials are complicated. The patients are very sick, you know, diffuse disease, you know better than me. Yeah, I think it's possible. I think we need the trial, like you said. We need to see, certainly the safety profile is improved. There's no question. You know, I need to see the data to really become a full believer this is going to be the right technology.
So, well, so to that end, Ulf, when can we expect SIRONA to read out? You've already completed enrollment. You're looking at about another year. Is that right?
Yeah, another year. We need. We finished in September this year, meaning plus 8 to 6 months. So by the 6 weeks, that means by the end of next year, we might be able to come up with the primary endpoint. So probably the beginning of next year.
That's pretty exciting. And Francesco, what about debate?
Early 2024.
Early 24. Okay.
2024,
What about
yeah,
debate?
so.
Yeah, I hope, really, I hope that in 1 year we will end the enrollment.
Right. So,
But will be challenging.
yeah, we appreciate it. And we know with LIMES how challenging enrollment is. Yeah, it's
LIMES will be very tricky. I think we need the full 2 years at least. We need additional study sites. But I think it's a very important trial. It's, of course, highly powered, but we want to have also a clear result afterwards and really answer the question.
Well, and Eddie's already shown us the way. He's accumulated a huge experience, and I think that now we're going to have, within 12 to 24 months, we're going to have significant data to drive clinical decision-making. It's a very exciting time. For several years, we were talking about paclitaxel, and now it's exciting to be talking about Sirolimus. So I think we've gone over time, and I want to thank our panelists and our audience and everybody who's going to be watching this as a recorded program. And we look forward to seeing you next year when we're going to have more data to talk about. Thanks very much.